Okay, so today we're going to talk about movement rules based on the AASM scoring manual. All right, so on the RPSGT exam, task A, there are 27 to 29 questions, which equates to about 89 to 96 points on the RPSGT exam. All right, so this is the task, the section on the exam in which movement rules are contained. So in this same task, task A on the blueprint, you also have a category of sleep stages, arousals, respiratory events and desaturations. You have movements, and you have cardiac events. So as far as the movements, which we're going to talk about today, they contain questions on any of the 7 movement types that's listed in the ASM scoring manual. All right, so what are the movement types listed in ASM scoring manual? So first we have PLMS, which stands for periodic limb movements in sleep. Then we have ALMA, which stands for alternating leg muscle activation. We have HFT, which stands for hypnagogic foot tremor. We have EFM, which stands for excessive fragmentary myoclonus. We have bruxism. We have RBD, which stands for REM sleep behavior disorder. And last but not least, we have rhythmic movement disorder. All right, so just take a minute to just see what you are already familiar with. By now, you have probably already heard of periodic limb movements. You have probably heard of REM sleep behavior disorder, and you may have heard of rhythmic movement disorder. All the rest are probably new to you, except with the exception of bruxism. All right, so the technical specifications. So we have 2 different pictures here. The top picture is about the leg EMG placement. This is the correct placement, electrode placement for our leg EMGs. And then on the bottom is the incorrect placement for the leg EMGs. The ASM manuals recently changed this. They recently updated the manual to include this because a lot of texts were putting it on like how we see at the bottom, like how we see the picture at the bottom, but actually the picture at the top is more correct. So as far as the wording in the manual, it says for limb movement, we're going to place electrodes longitudinally and symmetrically in the middle of the anterior tibialis muscle so that they are at least 2 to 3 centimeters apart, or 1/3 the length of the muscle, whichever is shorter. Okay, I highlighted shorter. I put that in red because that's definitely what they want you to go by. I mean, it's okay to know the 2 to 3 centimeters that you may be asked that on your exam, or you may be asked the 1/3 the length. But if you have an answer choice that says, whichever is shorter, then of course that's the answer choice that we want you to select. All right, so your leg EMG impedances need to be less than, keyword less than 10,000 ohms. So don't get on the test and you see 10,000 ohms and you just click that because that number stood out to you. No, it needs to be less than 10,000 ohms. Less than 5,000 is preferred, but it may be difficult to obtain. So what's required is less than 10K. What's preferred is less than 5K. Keep thinking of that word preferred. So if I ask you on the test, or if you're asked on the actual RPSGT exam, make sure that you know the difference of what you're being asked. Are you being asked what is the recommended leg EMG impedance, or are you being asked what's the preferred leg EMG impedance? All right, so moving on, still on our technical specifications. If we have to hook up any arm leads, this is how we do this. You can have arm leads and you can have arm bands. So this is how we would do the arm electrodes. So it's completely optional, but we can use this. It's similar placement can be used for detecting transient muscle activity during REM sleep. So if we are accessing REM, like the transient muscle activity during REM sleep. This is what we would do. The patient should bend their fingers at the base, which is what we see here. And the patient should also extend their fingers backwards without bending. So we basically put 2 electrodes on the one side of the arm, and then we have the patient to turn their arm over, and we put the 2 electrodes on the other side of the arm, which is what we see pictured. The use of a 60 hertz filter is not recommended. Impedance should also be less than 10,000 ohms, the same as with the legs. Any type of muscle activity, we still want it to be less than 10,000 ohms. Ideally, less than 5, but it may be more difficult to obtain. All right, video PSG monitoring. Time synchronized audio equipped video for the diagnosis of RBD, which is REM behavior disorder. What this means is that you have to have real time and audio at the same time in order to diagnose REM behavior disorder. That's basically what we're saying. The time and audio portions of the video have to be in sync with the polysomnogram. It's imperative to document complex motor behaviors and vocalizations during REM. So that means that if your patient seems like they are fighting, if they are saying different words, anything like that, make sure that you document that. It means that in order to have RBD, you have to have live audio and video recording and REM sleep without atonia on the polysomnogram. What is atonia? Atonia is lack of muscle movement, no muscle movement. So you have to have REM sleep without atonia. So that means that the muscles have to be moving, if that makes any sense. Atonia is no muscle movement. So if we say without atonia, that means that we're saying that the muscles are moving. So we have to have the live audio and video, and they would have to be moving their limbs in order for us to diagnose, in order for the doctor to diagnose RBD, because we don't, diagnose anything. All right, so time synchronized video is required to accurately characterize and to diagnose RMD. RMD is rhythmic movement disorder. Okay, this is a actual new, I want to say it's a new note in our updated manual. All right, so optional, we have surface electrodes should be utilized to record large muscle activity for rhythmic movement disorder. We're going to place the electrodes on the paraspinal muscles, okay, which is what you see right here, where we put it on each side of Miss Davis's spine. We had her to be our little guinea pig for recording purposes. So you will basically put it on each side of the patient's spine and the back of their head. So that's what we would put there. All right, technical specifications for bruxism. Additional masseter electrodes may be used for the detection of bruxism. Patients should bite down for correct placement. So you would ask the patient to bite down, and you will put them right here. If we're doing 2 leads, then we would do them 2 to 3 centimeters apart, just like we would do with the legs. Let's recap right quick about the legs. The legs, we would put them 2 to 3 centimeters apart, or 1/3 the length of the anterior tibialis muscle, whichever one is shorter, not longer, shorter. If we're only using 1 lead, then the chin serves as a reference. The use of a 60 hertz filter is not recommended. Our impedances, again, since they are muscle leads, we still want the impedances to be less than 10,000 ohms. Again, less than 5,000 is ideal. All right, so periodic limb movements in sleep. So it is recommended, that's why I have recommended in all red. It is recommended to score periodic limb movements in sleep. Okay, so we're going to score as follows. The minimum and maximum durations of a limb movement event is 0.5 to 10 seconds. Make sure that you know that. The minimum amplitude of a limb movement event is 8 microvolts above an 8 microvolt increase above resting EMG, so above your baseline. The limb movement event starts when there is an 8 microvolt increase in EMG voltage, and it ends when the EMG amplitude is no longer exceeds 2 microvolts above resting EMG. And I'm going to explain that because I know it's kind of hard to just hear that and understand what we're saying. The limb movement also has to happen for at least a half a second. Periodic limb movement sleep is formerly known as nocturnal myoclonus. Okay, I want you to know that because it will be on your test. PLMS is formerly known as nocturnal myoclonus. All right, so periodic limb movement disorder is diagnosed if the patient has a periodic limb movement index greater than, keyword greater than 15 per hour for adults, or greater than 5 per hour for children. So, periodic limb movement disorder, PLMD. PLMS is periodic limb movements in sleep. If they actually have the diagnosis, then we would call it PLMD. It's kind of like obstructive sleep apnea. You can have an obstructive apnea without being diagnosed with OSA. So if this patient has maybe 2 obstructive apneas per night, then they would not be diagnosed with obstructive sleep apnea. But of course, if they have more than 5 obstructive apneas per hour, then of course we would diagnose that as having obstructive sleep apnea. So it's the same thing with here. Periodic limb movements in sleep, that's just in all the individual movements. But if they have enough individual movements to classify for the disorder, then we would call it periodic limb movement disorder. Periodic limb movement, which is PLMD. So it's, once again, it's diagnosed when the PLM index is greater than 15 for adults or greater than 5 for children. Don't get on the test and you see 15 and you just select that because it's 15. Or don't just select 5 because it's 5. No, it has to be more than. So on your RPSGT exam, if you have answer choices are 4 and 5 and 6 and 7, then 6 would be the best choice for periodic limb movement index in children, to diagnose periodic limb movement disorder. All right, so would this or these be considered a periodic limb movement? What do you think? The answer is no. Although they exceed the amplitude requirement, so like they're definitely above the 8 UV increase. Now this little red line, this little dotted red line right here, it tells us whether or not we meet our 8 UV increase. But the reason why that this doesn't qualify as a periodic limb movement is because it doesn't meet the duration requirement. We just learned on a previous slide that it has to happen for at least a half a second. It has to be each periodic limb movement has to be at least 0.5 seconds to 10 seconds long. This is not 0.5 seconds. If we see these little green vertical dotted lines, that's our 1 second mark. So we have, so we have to take up at least half of that to have a half a second. These don't even take up even a quarter of that. So the duration doesn't qualify as a periodic limb movement. All right, so would this be considered a periodic limb movement? No. Even though it looks like a periodic limb movement, the presence of alpha waves is what rules it out. Limb movements cannot be scored during wakefulness. Okay, so the patient has alpha throughout the entire epoch. So this is why this is not a periodic limb movement. Now, if this patient was asleep, then yes, this would be considered a limb movement. Okay, the limb movement, it seems like it happens for a duration of about 3 seconds, between 3 and 4 seconds, I would say. All right, do you think this would be considered a periodic limb movement? No, again, we have alpha waves. Okay, we have alpha waves. Okay, would these be considered a periodic limb movement? Or do you think that it's one periodic limb movement? Do you think that we have two periodic limb movements present, or three? Or do you think that there are no periodic limb movements at all? Just, take a second to um, gather your thoughts. Yes, both events contain an amplitude of at least 8 UV. Like, even though the first example, the first circle is barely noticeable, technically it meets the definition because it is at least an 8 UV increase, okay, above your resting EMG, and it does last for at least half a second. So technically, the first circle does meet the qualifications. I mean, we know it's almost indisputable that the second one meets the criteria as well, but the first one also meets the criteria for a periodic limb movement. All right, so the following defines a periodic limb movement series. Now, we already went over what an individual periodic limb movement is, and we also went over how the doctor would diagnose periodic limb movement disorder. When the PLM index is greater than 15 for adults, or if it's greater than 5 for children. All right, so now we're going to tell how to have a periodic limb movement series. So the following defines a periodic limb movement series. So the minimum number of consecutive limb movements needed to score a periodic limb movement series is 4. So that means we have to have 4 individual periodic limb movements in order to have a periodic limb movement series. All right, the distance between the limb movements in order to be a part of the series is 5 to 90 seconds. 5 to 90 seconds, that will be on the test, okay? It's measured as the time between onsets of consecutive limb movements, the time between onsets. So you're going to measure your distance from the start of one limb movement to the start of the next limb movement, okay? Limb movements on 2 different legs separated by less than 5 seconds between movement onsets are counted as one leg movement. Let me read that again. Limb movements on 2 different legs, if they are less than 5 seconds in between the start of one leg movement and the start of the next leg movement, we're going to count both of them as just one leg movement. All right, so here's an example. So how many leg movements are present? We see one at or it appears to be one at the 10 to 11 second marker, and then we see another, what appears to be a leg movement at the 12 to 13 second marker, and then we see another limb movement at the almost 30 second marker. Do you think that all of these qualify as limb movements, or just one, or two, or none? One. Okay, it's only one because the left leg has one leg movement between the 12 and 13 second markers. Okay, that what we see, that's why I say what appears to be a leg movement. You have to pay attention to what channel you're looking at. Okay, so what appears to be a leg movement at first between the 10 to 11 second marker is actually in the snore channel. And the same thing with the what appears to be a leg movement that's almost in the 30 second marker. Both of those happen in the snore the snore channel, not the legs. Okay. Also, the 2 movements that are in the snore channel, well, let me not say movements, but the 2 pieces of activity, the snoring or whatever the case may be, it's in the snore channel, it may be that the patient coughed, and because the reason why I said the patient isn't snoring, because patients snore in a pattern. This is just a one thing, so they could have coughed or or just anything like that in their sleep. Also, even if the activity in the snore channel was in the leg channels, it still wouldn't qualify as a limb movement because it doesn't meet the duration requirement. They're not a half a second. The first one isn't a half a second, and the second one isn't at least a half a second either. So regardless of where it happened, it still wouldn't qualify as limb movements, even if they were in the right leg or left leg channel. All right, so how many leg movements are present now? One. One because of the rule that we just went over a few slides ago. If there is less than a half a second from the start of the first limb movement to the start of the next limb movement, then we're going to count both of them as one leg movement. So even though it appears to be, two, and it's on two different legs, we just read, if it's less than 5 seconds in between onsets, that means the start of one to the start of the next. If it's less than 5 seconds in between, then we count it as one. Okay. Can you score a limb movement that's associated with an arousal? Yes or no? Yes, you actually can, but only under certain circumstances. Okay, and we're going to talk about that in just a moment. All right, so let's define what means associated, okay? Because we asked you if you could score a limb movement that is associated with an arousal. How do we know something is associated? An arousal and a limb movement is considered associated with one another if they occur at the same time, which that's what simultaneously means. If they occur at the same time, if they overlap, or if there is less than a half a second between the end of one event and the onset of another event, regardless of which is first. Okay, that's how we determine whether or not they're considered associated. Make sure that you write this down. Make sure that you write plenty of note cards because this whole PowerPoint is going to be a lot of numbers. It's going to be a lot of numbers. It's going to be a lot of things to remember. So the best way to remember this is through repetition. Okay, because I don't want you to get confused with the association with the limb movement and arousal. I don't want you to get that confused with the limb movements on two different legs being counted as one. Like we measure that from the start, the onset of one event to the onset of the next one. But to determine whether or not a limb movement is associated with arousal, we measure that from the end of the first event to the onset of the next. Regardless of which one is first, the end of the first to the beginning of the second. Okay. All right, refer to page 52 of the AASM scoring manual for a visual demonstration. I'm not sure if that's the AASM scoring manual version 2.5 or version 2.6, but it should be right around, those pages so that you can get a visual of what we're talking about. But this is something similar that you're going to see in your AASM scoring manual. So, arousals that occur simultaneously with the limb movements are considered associated with one another. So in this example, and it took me a while to do this visually, in this example, we have a K complex, and then we have an arousal. Then we have a leg movement on our right anterior tibialis. And then we have another leg movement also on our right anterior tibialis, okay? The fact that these happen at the same time with our arousal, they're considered associated with one another. When periodic limb movements occur with an interval of less than 10 seconds, and each one is associated with an arousal, only the first arousal should be scored. Let me say that again. You have several periodic limb movements, and each periodic limb movement is happening less than 10 seconds away from each other. Like let's say every 9 seconds, you have a periodic limb movement associated with an arousal. Every 9 seconds. We're only going to score that first arousal. We're going to score all of the limb movements, but we're only going to score that first arousal that's associated with the limb movements. Okay? So, let's read that one more time just for clarity. When periodic limb movements occur with an interval of less than 10 seconds and each is associated with an arousal, only the first arousal will be scored. Both limb movements may be scored, but only one periodic limb movement associated with an arousal may be scored. Okay? That's what we're saying. If this, let's say the whole epic, you have a periodic limb movement every few seconds, every less than 10 seconds, every 5 seconds, let's say. Every 5 seconds, and each one of them are associated with an arousal. We're only going to score that first periodic limb movement. No, we're going to score all the periodic limb movements, but we're only going to score that first arousal. We can only score one periodic limb movement associated with an arousal. Okay. So this is an example. It says pretend that these arousals are limb movements and they were less than 10 seconds apart. Circled in red is everything that would be scored. Okay. Just take a second to grasp that. All right. Periodic limb movements in sleep. Once again, still, this is recommended. It's recommended that we score it. Okay. Do not score a periodic limb movement if it occurs half a second before or after a respiratory event. What is a respiratory event? Any type of apnea, hypopnea, rare, all of that. Okay. So any type of apnea, obstructive apnea, central apnea, mixed apnea, doesn't matter. Hypopnea, central apnea, obstructive, central hypopnea, obstructive hypopnea, it doesn't matter. Whatever, any type of respiratory event, we are not going to score a limb movement if it happens within a half a second before or after a respiratory event. All right, so if less than, keyword less than, if less than 90 seconds of wake separates a limb movement series, it should not prevent any subsequent or any following limb movements from being included in the series. So this is an example of what we're talking about. Okay, so we have our right anterior tibialis and we have our left anterior tibialis. Okay, we have what appears to be 5 leg movements. Okay, but do we count all 5 of them? Or do we count 4 or 3 or 2 or 1? How many do you think out of what we see will we count? The answer is that we have 4 leg movements. Even though it appears to be 5, we cannot score leg movements in wake. Okay, we do not score leg movements while the patient is awake. But our rule just told us that even if wake separates, if it's less than 90 seconds of wake that separates our leg movement series, then anything after that is still not going to stop that from being included in the series. Okay, so we know that our series could be between 5 to 90 seconds long, okay, in order to have a series. So that means, like, okay, the duration is 5 to 90. So that means that the max that we can do is 90 seconds from the start of one limb movement to the start of another limb movement. Let me say it again because that kind of sounds crazy. Our maximum duration for scoring a periodic limb movement series is 90 seconds. That's the maximum duration. What this means is that the max amount of time from the start of one limb movement to the start of another limb movement is 90 seconds. I can have no more than 90 seconds from the start of one limb movement to the start of the next. That doesn't mean from the first to the last. So let's say that you have, okay, like this example right here. Let's pretend that all 5 of these were considered leg movements. We're not going to say from the start of the very first limb movement to the start of the last limb movement has to be 90 seconds. No, that's not what we're saying. We're saying like in order to be included in the series, it's just from the start of one to the start of the next. Okay? So not the start of the first to the start of the last. So if you have 10 leg movements, we're not going 90 seconds from the start of the one to the start of the 10th one. Okay? We're going from the start of what's the distance from the start of the first to the second one? Or what's the distance from the start of the ninth leg movement to the start of the 10th leg movement? I hope you really understand what I'm saying. What I'm saying is your 90 seconds duration is from the start of one to the start of the next. It's not saying that all leg movements have to occur within a 90-second duration. That's not what they're saying at all. And then also we can have more than 4 limb movements in a series. It's just saying that our minimum number to have a series of leg movements is 4. We can have 10, we can have 18, we can have however many. All right, so according to the ASM scoring manual, the scoring of which movements are optional. So let's go back to I think it was our second slide. Just think about all 7 of our movements. We already went over periodic limb movements, so that's 1. Then we have alternating leg muscle activity. We have hypnagogic foot tremor. We have excessive fragmentary myoclonus. We have bruxism. We have REM behavior disorder. We have rhythmic movement disorder. So that's 7. So out of all 7 of those, how many do you think are optional? Or how many do you think any of them are optional, or all of them recommended? Or which one? I think a better question is, if you do think that any of them are optional, which ones do you think that are optional for us to score? Which ones do we not have to score? All right, so it's only 3. 3 of the 7 listed in our manual we do not have to score. We do not have to score HFT. We do not have to score EFM. And we do not have to score alternating leg muscle activation. Now, recently, one of my former students took the RPSGT exam, and she did have some questions on there about excessive fragmentary myoclonus. Okay, that's not a guarantee that you will have the same thing, but it's definitely important to know about it's only 7. So it's important to know about all 7 of the leg movements listed, because you never know which ones that you're going to get, or how many of which ones that you're going to get. All right. Well, I just did this for you. I forgot that this slide was coming up next, so we're just going to move on. All right, so let me go back. So keep in mind all 7 of these, okay? PLMS, ALMA, HFT, EFM, bruxism, RBD, RMD. Get a visual picture of that, because I'm going to show you a picture, and I want you to guess which one of these listed is in the picture, okay? So what do you think this movement is? Just take a second. Also, what stage of sleep do you think the patient is in? ALMA, alternating leg muscle activation. You notice how they're moving one leg, then they move the other, then they move the one, and then the other, then the other. It just keeps going back and forth. That doesn't mean that every single movement is one, then the next leg, one, and next leg. So sometimes it skips, but this is still an example of alternating leg muscle activity. And I would say that this stage of sleep is REM as well. All right, so the scoring of ALMA is optional. We just went over that. The minimum number of discrete alternating EMG bursts needed to score a series is 4. So it's the same thing with periodic limb movements series. You also need a minimum of 4 to score that. You need a minimum of 4 to have a series of ALMAs. The minimum frequency is 0.5 hertz. The maximum frequency is 3 hertz. Once again, I don't expect you to remember this right off the bat. That's why I expect you to write note cards. because the test will be very difficult if you do not. There are plenty, plenty, plenty of numbers on this whole PowerPoint. Probably the most numbers that you've had thus far in the class. All right, so name this movement. What do you think this movement is? This movement is excessive fragmentary myoclonus. Now, when you do your inner score reliability, I'm pretty sure you see little stuff, things like this all the time. Like little spikes. It looks like little spikes. To me, it looks like little spikes in the leg channels, the leg EMG channels. And just think about it. The reason why this makes sense for it not to be required for us to score these, because this happens all the time. Like you will literally be all night trying to score every single one of these. Okay? That's why it's not recommended to score. Now, if you're just bored and you don't have anything else to do and you won't get fussed at from doing it, then by all means knock yourself out and score every single one of them. But I think it would be very, very, very time consuming to have to score every single EFM movement. Okay, so that's why it makes sense for it not to be recommended. Okay, the same thing with alternating leg muscle activity. I mean, if a patient has it, pretty much it's going to be just back and forth, back and forth. You know, move this leg, then move that leg, then move that leg. You know, we don't really have that type of time on our hands to just score every single one of those. So this is why it makes sense. All right, so the usual, okay, I put usual in quotes because that's what it said. It said usual. It didn't say the recommended or anything like that. It just said usual. It said the usual maximum burst duration is 150 microseconds, which I calculated for you to 0.15 seconds. You're welcome. Instead of asking you on the test what is 150 microseconds in seconds, here it is. I just did it for you. All right, so it's 0.15 seconds. So it's really quick, okay? At least we know that with a periodic limb movement, it has to be at least a half a second. This is like 0.15 seconds. Like it's not even, you know, it's not even a quarter of a second. So they're really, really quick. And this is the maximum burst, the usual maximum, okay? So it could be very, very quick. All right, at least 20 minutes of non-REM sleep must be recorded if we're going to score EFM. Then we have to have at least, keyword again, at least 20 minutes of non-REM sleep must be recorded. Also, at least 5 EMG potentials per minute must be recorded. That's a lot. That's, once again, this is why we don't recommend that you score this. Who has time to literally count 5 of these little things every single minute? Okay, considering the fact that a normal sleep study has to happen for at least 6 hours. So if you want to go and count at least 5 of these every minute, once again, knock yourself out. Okay, but it will literally take you all night, and especially with 2 patients. All right, so name this event. Look at the red, what we have going on in the left leg. Look at this, and then name this event. Hypnagogic foot tremor, okay? A foot tremor is like twitching, okay? It's almost like your foot is twitching or shaking or something like that. So you see it's even more of these than it is of the excessive fragmentary myoclonus that we just went over, you know, the EFM. So this is another reason why it's not recommended to score this. You will be all night once again. All right, scoring of HFT is optional. We already know that. The minimum number of discrete alternating EMG bursts needed to score a train. We call this a train. Now, we call the other ones that we just went over a series. The ALMA is a series and periodic limb movement is a series. Now, HFT, we're saying that it's a train. So we need at least 4 to have a train, okay? The minimum frequency is 0.3 hertz, okay? So that's the speed. The maximum frequency is 4 hertz, okay? Once again, numbers, numbers, numbers. So just make sure that you do your note cards. All right, name this event. Now, everybody should probably know what this is. Bruxism. This is bruxism, okay? It's like bruxism should never be mistaken for anything else. To me, it's just so distinct till you should definitely be able to look at it and recognize what it is. This is an example of bruxism, of the audible bruxism. All right, well, I don't know if you can hear that, but it was like at least two different episodes where we could actually hear his teeth grinding right after I finished talking, and then another right before the video ended. The reason why I put this on here because in order to score bruxism, you also have to have like audible episodes as well. So this is what your teeth can look like if you grind your teeth, okay? And nobody wants that. All right, so it's two different ways to score bruxism. We'll get into that in a minute, okay? But first, let's recognize the fact that scoring a bruxism is recommended. I forgot to put that in all red, but make sure that you highlight that. Make sure that you know that bruxism is recommended to score, okay? So we can have brief bruxism, which is phasic, or we can have sustained bruxism, which is tonic, okay? So phasic means brief, tonic means sustained. Sustained means lasting longer than normal, okay? So brief or sustained elevations in the chin EMG, that's at least twice the amplitude of background EMG. So let's go back a few slides so that we can know what we're talking about. Okay, so these are what we call brief episodes of bruxism, okay? It's not sustained, but it's brief, okay? So the amplitude is at least twice the background EMG amplitude. I would say it's even more than that. You know, it might be 4 or 5 times the background amplitude, but you definitely would see a difference in the background amplitude when you're scoring bruxism. All right, so if we're scoring brief bruxism, our duration is at least 0.25 to 2 seconds, okay? So at least a quarter of a second to 2 seconds. Let me say it again. In order to score a brief bruxism, the duration needs to be at least a quarter of a second, which is 0.25 seconds to 2 seconds, okay? Also, we have to have at least 3 elevations in a regular sequence, okay? At least 3 elevations. So let's go back to our example, okay? I would say the first 3 are our 3 elevations that are at least a quarter of a second to 2 seconds, and then they do occur, and we do have at least 3 that occur in a regular sequence. But the last 3 are not in a regular sequence. All right, so in order to score a sustained bruxism, the duration is more than 2 seconds, okay? It has to be more than 2 seconds, and we have to have at least, once again, let me say that, at least 3 seconds of stable background EMG must occur before a new episode of bruxism can be scored, okay? The diagnosis of bruxism, so regardless of if you're doing brief or sustained bruxism, the diagnosis requires at least 2 audible episodes. So what this means is that if you see what appears to be bruxism on the polysomnogram. You have to make sure that you are paying extra attention to the video of your patient because you have to hear the audible tooth grinding and you have to mark it on the polysomnogram as that occurs. That's the only way bruxism, I was about to say can be diagnosed, but that's the only way bruxism should be diagnosed according to the AASM score manual. So you can have the physical criteria on the polysomnogram, but you also have to have the audible criteria, at least two, where you can hear the patient actually grinding their teeth. Okay, it has to happen during the night without seizures, so it doesn't count if the patient is having a seizure. Okay, if they are grinding their teeth at least 2 times during the night, in addition to the polysomnogram evidence, then we can score either brief or sustained bruxism. All right, so name this movement, which this is a lot going on, and the patient also appears to be in REM. I think I kind of gave it away by saying that the patient also appears to be in REM, but this is REM sleep behavior disorder. Me personally, I just say REM behavior disorder. RBD. I don't know why they say REM sleep behavior disorder, because why they just won't say RSBD, you know. But anytime I say RBD, that's what I think of in my head, REM behavior disorder. Me personally, I don't care if you say, if I ask you on the test, if you say REM behavior disorder or if you say REM sleep behavior disorder, I don't care. I won't take off for that. All right, let's listen to the video. Uh-oh, let me go back. All righty, just a little insight on RBD, REM sleep behavior disorder. All right, so REM sleep behavior disorder is recommended. Make sure you highlight recommended. Okay, we're going to score it as follows. We're going to score as sustained muscle activity, which is tonic. Tonic is sustained. Sustained is tonic. Okay, meaning lasting longer than normal. We're going to score as sustained muscle activity if an epic on the REM sleep with more than, I need to double check and see if it's more than or at least, I think it's just more than 50% of the epic having a chin amplitude higher than the minimum amplitude that's seen in non-REM sleep. Let me say it again. We're going to score a sustained muscle activity if an epic on REM sleep, well, when we have let's say, let me put it in my own words, okay? We have a REM sleep epic with more than half of the epic containing a chin amplitude higher than the minimum that we saw when the patient was not in REM. Say that once again for clarity. We have a REM epic when more than half of the epic, okay? More than half of the epic has a chin amplitude that's higher than the minimum amplitude that we saw when the patient was not in REM. Okay. Why this makes sense is because normally in REM sleep, we're looking for the chin EMG to be actually lower in amplitude than in non-REM. You know, usually we look for the chin amplitude in REM to be lower than the chin amplitude in non-REM. But RBD is just opposite. We're actually looking for the chin in REM to actually be higher than what we saw in non-REM. We want it to be higher than the minimum that we saw in non-REM. Not the maximum, higher than the minimum that we saw in non-REM. All right, so excessive transient muscle activity, which is more common. Excessive transient muscle activity, we're going to score that in a 30-second epic. If we divide this 30-second epic into 10 3-second epics, then at least 5, so at least 50% of these mini epics have to contain bursts of transient muscle activity. Okay, transient muscle activity bursts are 0.1 to 5 seconds in duration. Okay, and at least 4 times the amplitude of the background EMG. I put all of that in red because it will be on your test. Okay, excessive transient muscle activity. If we were to break down a 30-second epic into 10 individual 3-second epics, at least 5 of those epics have to contain transient muscle activity. I'm going to show you a picture of what transient muscle activity looks like. But the bursts are at least 0.1 to 5 seconds long. And it has to be at least 4 times the amplitude of the background EMG. So remember the picture that we just saw of bruxism? It has to be like that. It has to be at least about 4 times the amplitude of the background EMG. So it has to be high. The amplitude is height. It has to be 4 times as high. Okay. RBD characteristics have either or both of the following. I know that you all hate those type of terms, either or both, but that's what's listed in your manual. They either sustain muscle activity during REM sleep in the chin EMG, or we can have excessive transient muscle activity during REM in the chin or leg EMG, or we can have both. Okay, either or both. Sustained muscle activity during REM is only going to be in the chin. We're only looking at the chin leads. If we're looking at excessive transient muscle activity during REM, we got to look at the chin channel, and we got to look at the leg channel. Well, chin or leg. Let me clarify that. Excessive is the only one that could be either in the chin or leg channel. Sustained muscle activity is only in the chin. Make sure that you know that for the test. All right, aggregates of which protein are most associated with REM sleep behavior disorder? What do you think? I know that you have probably not heard of any of these. This is just a practice question, a RPSGT practice test question, but I still wanted you all to know that. So aggregates or concentrate, let's just say concentrations. Concentrations of which protein, like I said, you may not have even heard of these proteins, but are most associated with REM sleep behavior disorder. C. Again, make sure that you know this for the test. I think the next couple of slides are going to be, well, at least toward the end of the PowerPoint, we're going to have a lot of things like these. I'm starting to call these self-study questions, whereas I put questions that's actually going to be on your upcoming test. I'm actually starting to put those in the PowerPoint now. So make sure that you definitely write note cards on any questions that you are asked during the PowerPoint because it's like a 100% chance you will see that on your upcoming test. All right, so tricyclic antidepressants or SSRIs may do what? They may cause or worsen REM behavior disorder. They may reduce periodic limb movements during sleep. They may reduce restless leg syndrome, or they may shorten REM latency. Which ones do you think tricyclic antidepressants or SSRIs would do? A, they're going to cause or worsen REM behavior disorder. All right, so, this picture is very, very blurry. I apologize about that, but name this movement. Well, what you think this movement will be. Rhythmic movement disorder. Once again, it is very, very hard to see. Hopefully I have another picture, or maybe you can just Google rhythmic movement disorder on the polysomnogram, and maybe you could get better clarification, okay? But rhythmic movement disorder is recommended to score this. We're going to score rhythmic movement disorder as follows. Our minimum frequency is a half a second. Our maximum frequency is 2 seconds, or 2 hertz, should I say. Minimum number of movements to make a cluster. So this is called a cluster. It's 4. I don't know why they wouldn't just call everything a series just to simplify everything, but they didn't. So this is a cluster. We just learned that the HFT was, I think it was called a train. A train is at least 4. Cluster of rhythmic movement disorder is at least 4. The ALMA and the periodic limb movement, that both of those are called series, and the minimum number of movements for those are also 4. So far everything is 4 so far. Minimum amplitude is twice the background EMG. Okay, let's go back. The minimum is at least twice the background amplitude EMG, which is what we see here. It's very hard to see, but that's what's going on here. Which of the following is an example of a rhythmic movement disorder? Now, you should definitely know this. And this actually came from the ATL. They had a class, like a little scoring class, and they actually, this was their board review. This was on their board review that they had a couple years ago. So this is one of their practice test questions. Which of the following is an example of a rhythmic movement disorder? The answer is D, okay? I also had a previous student to tell me, this was maybe about 3 or 4 years ago, so I don't know if it will apply to you all, but just in case, she said that she actually did have this on her actual exam, that they asked her about ejectatio capitis nocturnal. Okay, somnambulism means sleepwalking. Pavor or pavor, however you want to say it, I say pavor. Pavor nocturnus is night terrors or sleep terrors. Somniloquy is called sleepwalking. Ejectatio capitis nocturnia is called head banging. And cataplexy, that's when we have any type of muscle weakness caused by laughter or strong emotion. When patients have narcolepsy, but they have cataplexy, then this is what they do when they laugh or they are scared or anything. I don't know if y'all have seen it or not, but the videos of the goats, when you scare the goat and then they just pass out, that means that their goat has cataplexy. That any type of strong emotion, their muscles just get weak and they just pass out. Okay. But anyway, all of these are movement disorders. Well, except for cataplexy, it's like the exact opposite. It's like a lack of movement actually. But everything else is a movement disorder. But the key word is rhythmic movement disorder. Sleepwalking, that's not necessarily rhythmic. You can sleepwalk and it not be in a rhythmic pattern. You can have night terrors or sleep terrors. That's definitely not rhythmic. They could just, you could probably just scream one time and that's it. Sleep talking, the same thing. You might just say one sentence and that's it, or a couple words. Head banging, that's repetitive. I'm constantly banging my head on the headboard or whatever it is. This is very common in children. Sometimes they do this to try to help themselves sleep. Well, let me clarify, not children, but babies. Sometimes babies will rock their heads, you know. Sometimes babies, you have to shake them real hard, like rock them real hard in order for them to fall asleep. Okay, like so they're not rocking their own heads, but they want you to do it. They want you to rock their whole body to help them fall asleep. All right, so this is my comparison chart that I did for you all. It also took me a while to do this, but I did it just for clarification purposes because I think it'll help you better understand. So everything is recommended has a yes stamp on it. Okay, so transient muscle activity, which is a part of REM behavior disorder, that's recommended. Bruxism is recommended. REMD is recommended, and periodic limb movements is recommended. I'm not going to go over the duration and the amplitudes and what's the number that's qualified for a group or anything like that, because y'all will do that on your own time when you do your note cards. We already went over it on the slides. So, all right, now let's talk about restless leg syndromes, because several students have told me that respiratory legs, they had several questions on restless leg syndrome on their RPSGT exam. All right, so restless leg syndrome is not covered in the sleep disorders chapter. There's review in the first semester, but we will do just a quick review, on this PowerPoint just to try to refresh our memory, okay? All right, so leg movements, both periodic limb movements in sleep and the occurrence of restless leg syndrome are increased during pregnancy. If a woman is pregnant, she will more than likely have periodic limb movements in her sleep. She will more than likely have restless leg syndrome. What's the difference between the two? Which one happens while you're awake, and which one happens while you're asleep? Restless legs happens while the patient is awake. Periodic limb movements will happen while the patient is asleep. You will need polysomnographic evidence. That means you need a PSG done in order to diagnose periodic limb movement disorder. You do not need a PSG to diagnose restless legs. You just go to your doctor and complain about it, and now you are diagnosed, okay? They don't need, it's a waste of money. They wouldn't spend $3,000 on a test, and all you can do is just simply tell them. They don't need you to fall asleep. They just need to see you move your legs, before you fall asleep. That's all they need. Restless leg syndrome can increase sleep latency, which makes sense. Think about it. Sleep latency is the time it takes you to fall asleep. If you're constantly moving your legs and you can't get comfortable, that's going to increase the time that it takes you to fall asleep. Whereas normal people probably could fall asleep in 5 minutes, it might take you 25, it might take you 45, because you can't get comfortable, you keep moving. Okay, you can't be still, so that's why it's going to increase your sleep latency. All right, periodic limb movements in sleep, it can increase nocturnal awakenings, which makes sense. Think about it. You're asleep and you're constantly moving your legs, you're probably more likely to wake up during some of those movements. And it's also going to increase your arousals for the same reason. When you wake up, you're probably going to have an EEG arousal. Okay? Periodic limb movements can also decrease sleep efficiency. Sleep efficiency is how well or how much I slept during the night. So if I was in the bed for 8 hours and I slept 95% of that time, that's great. But if I have periodic limb movements, I might not sleep 95% of the time that I laid in bed. I might sleep a lot less, because think about it. If I'm waking up a lot and I'm having a lot of arousals, I'm probably not going to sleep a whole lot. So that's why my sleep efficiency will be actually decreased. I won't sleep as much throughout the night. All right, restless leg syndrome can occur at any age. Restless leg syndrome in children is often misdiagnosed as hyperactivity or growing pains. Let me say it again. Restless legs in children is often misdiagnosed as hyperactivity or growing pains. Okay. Think about where do we see this word hyperactivity recently? I think we had a question that said something about if a child has a OSA. Sometimes OSA could be associated with hyperactivity. Okay. The most common medical condition associated with RLS is iron deficiency. Okay. It may be that that patient is lacking iron, which is the reason why they keep moving their legs at night trying to get comfortable. Okay. Also, think about this. They already told you that both periodic limb movements and restless legs um, is common in pregnant women. Pregnant women a lot of times lack iron. Okay. So that might be the cause of it. That's the most common medical condition associated with restless leg syndrome is iron deficiency. Other conditions associated with restless leg syndrome include obstructive sleep apnea. It includes Parkinson's. Parkinson's is like, when they shake real bad. Diabetes, renal failure, and rheumatoid arthritis. All right, which medication would keyword most, likely be used for the treatment of restless leg syndrome? Propinerol. Okay, I think you can also give them gabapentin, but the key word is most likely. Okay, so that's the only one that I want you to just really focus on right now. Okay, most likely that's what the doctor will prescribe. If you tell the doctor that you move your legs at night, can't fall asleep, they're gonna probably give you this. Which of the following statements is not true concerning restless leg syndrome? A is RLS must be diagnosed via polysomnogram. B, an essential feature of restless leg syndrome is an irresistible need to move the limbs. C, many people with restless leg syndrome also have periodic limb movements. Or D, the pathophysiology of restless leg syndrome is unknown. Which of the following is not true? A, because I just told you that you do not need a PSG to determine restless leg syndrome. Like I said, it'd be a waste of $3,000. Dopamine agonists, opioids, anticonvulsants, and benzodiazepines are therapeutic interventions for what? Is this restless leg syndrome? Is it nocturnal leg cramps? Is it excessive fragmentary myoclonus? Or is it alternating leg muscle activation? Of course, it would be restless leg syndrome because that's currently what we're discussing. Okay, so all of these are therapeutic interventions for restless leg syndrome. All right, hold on. So this is my self-study questions that I was telling you about. From now on, to save time, instead of like giving you a whole lecture on certain things and all of that, I'm just gonna cut straight to the chase and just give you the question that I want you to know, as well as the answer that I want you to know to the question. And I want you to write no cards on these so that you can drill them in your head, because more than likely you will see many of your self-study questions also on your final exam. All right, so which leg muscle should be monitored to detect limb movements? The answer is D, but I think you already knew that. All right, which of the following PSG characteristics of which of the following are PSG characteristics of REM behavior disorder? All right. The answer is A, sustained chin EMG during stage R, or increased transient muscle activity in the chin or leg EMG during REM. Even though this was the very first answer choice, I hope that you didn't just read this and just automatically select A. I still want you to read all answer choices because even though one answer may be correct, another answer may be the best option, which is what we just went over with the restless leg syndrome. We can use gabapentin to cure, as a treatment for restless leg syndrome as well. But the key word was which is most likely. Which one is most likely that the physician is going to prescribe? It's going to be propinerol. It's important for the technologist to ask for a brief medical history because why? All right, the answer is A. Patients may forget to discuss certain items with their physician. Okay, that's why we want to ask the patient about their medical history. Okay, as we're hooking them up, tell me a little bit about your medical history. You know, also make sure that you look on their chart as well. An organization dedicated to improving public health and safety by achieving understanding of sleep and sleep disorders is what? The National Sleep Foundation is an organization dedicated to improving public health and safety by achieving understanding of sleep and sleep disorders. The National Sleep Foundation. This is actually our PSGT question as well. The minimum number of consecutive limb movement events to define a periodic limb movement series is what? 4. We've been over there multiple times. The primary factor in effective patient education requires establishing what? Establishing a report or rapport with the patient and acquiring trust. This is also a board question. How often does assessment of score reliability need to be done? How often does assessment of score reliability need to be done? Quarterly. Score reliability is your ISR. And even though they call it interscore reliability, you know, but the book says scorer reliability. It's the same thing. It's one and the same. It needs to be done on a quarterly basis. You all do it more often now because you're in school, but once you become techs, you probably have to do it about every 3 months. Your PSG patient is a 4-year-old female with excessive daytime sleepiness. During the study, you notice she rolls her head while asleep. She likely has what? Rhythmic movement disorder. Okay? Rhythmic movement disorder. While falling asleep, your 70-year-old male patient awakens with severe pain in his calves. He likely has what? I think it's something that we haven't went over yet, but once again, it's a self-study, so I didn't want to make a whole slide just to inform you of one little thing. But it's called nocturnal leg cramps. Okay, nocturnal leg cramps. It's common in just nighttime leg cramps. It's common in pregnant women and it's common in older people. Sometimes their legs will cramp up at night while they're trying to sleep. It's also called sleep-related leg cramps. They are sudden, intense muscle cramps in the legs during sleep and can last up to several minutes. They are most common, keyword most common in the elderly. They are common in pregnant women as well, but keyword most common in the elderly, aka what kind of patients? Is it pediatric? Is it geriatric? Is it bariatric? Okay, it's geriatric. Elderly is also called geriatric patients. Your patient reports having bizarre and sometimes violent episodes during sleep. He may have what? This should be an easy one. A parasomnia, aka, well, more specifically, REM behavior disorder. REM behavior disorder is called a parasomnia. Parasomnia is an unwanted movement or action during sleep. Okay, so parasomnia, like Sleep talking, sleepwalking, all of those, night terror, all of those fall under the category of parasomnias. Okay, you're doing it in your sleep. You don't really want to do it, you know, but your body just does it. It's unwanted movement or action during sleep. Periodic limb movement disorder worsens during REM sleep. Is this true or false? I'm sorry, I may have read that wrong. Periodic limb movement disorder worsens during REM sleep. True or false? False. PLMD is not usually seen during REM because of muscle atonia. Think about it. Your muscles are without movement. Atonia means without movement. In REM, normally you don't even have muscle activity unless the patient has a RBD, REM sleep behavior disorder. Okay. Periodic limb movement is mostly seen in stage 2. Okay. Make sure you know that because it's going to be on the test. Periodic limb movement is mostly seen in stage 2. Twitching movements of the fingers, toes, and mouth may occur during stage wake. May occur during stage wake, stage non-REM, and stage REM. And it's known as what? Think about twitching of the fingers, toes, and mouth. Excessive fragmentary myoclonus. A disorder characterized by irresistible urge to move the body in an effort to stop uncomfortable or odd sensations, most often in the legs. What would that be? A disorder characterized by irresistible urge to move the body in an effort to stop uncomfortable or odd sensations, most often in the legs. What disorder would that be? Restless leg syndrome. Blank is the grinding of the teeth or clenching of the jaw during sleep. Bruxism. It is most commonly seen in children and adolescents. Once again, I can't stress enough, please make sure that you do your note cards. We're down to the wire. We only have a few more classes to go. Make sure that all your test grades from here on out are A's or very close to A's. So make sure you do those note cards. For many, a dental appliance such as a mouth guard can be effective in treating further damage to the teeth. Okay. All right, the end. I know it's kind of difficult. Well, not difficult, but it was kind of different with me doing this during just recording my screen versus talking one-on-one where you all can ask questions and I can ask you questions. But if you have any questions, please do not hesitate to reach out to me. You can inbox me via Canvas. You can reach out to me via text. If you even have to call me, then just call me. But I really, really encourage you to answer questions. I really, really encourage you to study. I really, really encourage you to do note cards. Okay. And so if you have any questions, just please do not hesitate to reach out to me.